Hello everyone, welcome back to another section of Dentistry and more. Today we are going to discuss the previous year question paper that has comes under the topics Management of Discolored Tooth, Minimally Invasive Dentistry, Cervical Lesion, Dental Ceramics, Pathologies of Pulp and Periapical Lesions, Endodontic Microbiology, Diagnostic Procedure, and last one is Pharmacology in Endodontics. So we are moving to the first topic, that is management of discolored tooth. The long essay include what are the causes for discoloration of teeth, classify bleaching technique and describe in detail about vital bleaching technique. Short notes includes carbamide peroxide, different vital bleaching technique, night guard bleaching, bleaching agents and walking bleaching technique. First one is causes for discoloration of teeth. Causes mainly includes both intrinsic stain and also extrinsic stain. So this intrinsic stain, it commonly consists of two types, that is pre-eruptive and also post-eruptive. In case of pre-eruptive, it can be due to any disease or due to any medication. And in case of post-eruptive, it can be due to pulpal changes, trauma, dental caries, aging, etc. In case of extrinsic staining, due to any daily acquired stains and also due to chemicals. In case of daily acquired stains, due to plaque, food and beverages, tobacco use, poor oral hygiene, etc. And chemicals like chlorhexidine and metallic stains. Next one is bleaching technique. So the bleaching technique can be of two types, that is vital and also non-vital. In case of vital, consists of at home and office, and also non-vital at home and office. In case of vital at home, it's home bleaching or night guard technique is used, and in case of in office, it is thermocatalytic, non-thermocatalytic, microabrasion and also laser assisted. In case of non-vital, the techniques used are walking bleaching, modified walking bleaching and closed chamber, and also thermocatalytic and laser assisted under in office. So these are the bleaching technique, and this flowchart is very important. Now we are moving to the bleaching agents. First one is hydrogen peroxide. This hydrogen peroxide, it can be used in a concentration that is ranging from 5 to 35%. So it can easily penetrate into the dentine and it releases oxygen, and the common properties are it is clear, colorless, odorless liquid that is stored in light proof bottles, and its shelf life is 3 to 4 months. So it should be handled carefully to prevent direct contact with the mucous membrane. It can be used alone or in combination with sodium perborate. So this is hydrogen peroxide. Next we are moving to sodium perborate. So this is available as white powder, and there are mainly three types, that is sodium perborate monohydrate, trihydrate and also tetrahydrate. So it will decomposes into sodium metaborate, water and oxygen when it is mixed with the superol. Next one is carbamide peroxide. So it is also known as urea hydrogen peroxide, and its concentration is 3 to 45%. So in the flowchart, there is a mechanism of action of carbamide peroxide. So this carbamide peroxide, it may decomposes into urea and hydrogen peroxide, and this urea, it leads or it releases carbon dioxide, ammonia, and hydrogen peroxide releases oxygen, water and also free radical. So you can note the flowchart. Next one is vital bleaching technique. So under that, first one is home bleaching technique or night guard bleaching. So the indications and contraindications, you can note one or two indications and contraindications. Like in case of indication, that is age related discoloration, mild generalized staining, mild tetracycline staining, mild fluorosis. In case of contraindication, it cannot be used in insufficient enamel for bleaching if there is any cracks or fracture lines, and in case of large pulp chambers, there is severe tetracycline staining and also sensitivity to heat, cold or sweets. Next one is the commonly used solutions. In case of this, the used solutions are 10% carbamide peroxide with or without carbopol, and 15% carbamide peroxide or hydrogen peroxide can be used. So next one is steps for tray fabrication. So in the figure you can see a bleaching tray. So first one is the impression is taken, after that the model is trimmed, and the stock resin is placed and is cured it. After that separating medium is applied and the tray sheet material is used. The commonly used material is ethyl vinyl acetate. After that the plastic in vacuum tray forming machines. After that is trimmed and polished, and it is checked for correct fit retention or if there is any over extension and all. And after that the bleaching material is placed over in order to demonstrate. Next one is the thickness of the tray. The standard thickness is about 0.035 inches, and normally there is thicker tray and also thinner tray. This thicker tray is commonly used in case of patients with breaking habits, and thinner is used in patients with gag reflex. Next one is the treatment regimen. So the patient is instructed to brush the teeth before tray application. After that this bleaching material, it is placed into the tray to cover the facial surface of the teeth, and after it is seating into the mouth, if there is any extra material is placed, it is wiped away. So this overnight use may cause decrease in loss of material due to any decreased salivary flow at night. And while removing the tray, the patient is asked to remove the tray from the second molar region. So this is to avoid the injury to the soft tissue. After that the patient is instructed to rinse off the bleaching agent, and this duration of the treatment, it may depends upon the discoloration or duration of the bleaching and time of bleaching, somewhere like that. And this patient is also recalled for any periodic checkups. Next one is side effects, and the side effects commonly includes gingival irritation, soft tissue irritation, altered taste sensation and tooth sensitivity. And also here you can see the advantages and also disadvantages, and you can note one or two advantages or disadvantages. Next one is in-office bleaching, and under that first one was thermocatalytic vital tooth bleaching. So here also you can see the indications and also contraindications. So you can refer from here. And the equipment needed, here you can see the powder, bleach material, tissue protector. You can write the equipments that are needed. And next one is the procedure. So here the teeth is pumice to clean off any debris, and the teeth is isolated with rubber dam, and saturate the cotton or gauze piece with bleaching solution, and depending upon the light the teeth is exposed. After that change the solution in between 4 to 5 minutes, and the treatment time should not exceed 30 minutes. After that remove the solution with the help of a wet gauze, and irrigate the teeth thoroughly with warm water, and the teeth is polished and it is applied with neutral sodium fluoride gel, and the patient is instructed to use the fluoride rinse on daily, and the second and third appointment is given after 3 to 6 weeks. Here also you can see the advantages and disadvantages. You can refer or write any of the advantage and disadvantage. Next one is non-thermocatalytic bleaching. So in this technique the heat source is not used. So you can see the figure. And the steps mainly include the teeth is isolated with rubber dam, and this bleaching agent is applied over the teeth for 5 minutes, and the teeth is washed with warm water, and the bleaching agent is reapplied till the desired color is achieved, and after that the teeth is washed and is polished then. Next one is microabrasion. So this is a very important question. So this is a procedure in which the microscopic layer of the enamel, it is simultaneously eroded and abraded with a special compound, that is usually 18% of hydrochloric acid, that by leaving a perfect intact enamel surface behind. So you can see the indications and contraindications. So you can note one or two indications like stains and discoloration, that is limited to superficial enamel only, and contraindications like deep enamel and dentin stains, And advantages and disadvantages. In case of advantage, there is minimum discomfort to patient, less chairside time. Disadvantage, it is not effective in case of deeper stains and it does not remove. It will remove the enamel layer. Next one is the protocol of microabrasion, that is clinically evaluate the teeth. Now clean the teeth with rubber cup and prophylaxis paste, and the petroleum jelly is applied and the teeth area is isolated with rubber dam. After that, this microabrasion compound that is placed over the area for 60-second intervals, and after that it is rinsed. Repeat the procedure if necessary, and the teeth is rinsed for 30 seconds and the teeth is dried. The topical fluoride is applied to the teeth for 4 minutes, and the color of the teeth is re-evaluated, and if the more visit is needed, then the patient is recalled. Next one is intracoronal bleaching or walking bleaching for non-vital teeth. Here you can see the indications and contraindications. And the steps include, first one is the radiograph is taken to assess the quality and evaluate the quality and shade of the restoration, and the tooth color is evaluated, and the tooth is isolated with rubber dam, and the assessed cavity is prepared, the removal GP and exposed dentine and refine the cavity. After that, place the mechanical barrier of 2 mm thick, preferably of GIC, zinc phosphate, polycarboxylate cement, MTA on the root canal filling material. The coronal height of the barrier should protect the dentinal tubules and conform to the external epithelial attachment. And now mix the sodium perborate with an inert liquid and it is placed over the pulp chamber. In case of severe stains, add 3% of hydrogen peroxide to make a paste. After removing the excess bleaching paste, over that a temporary restoration is placed, and by using the gloved finger, the pressure is applied over the teeth till it becomes filled, and after that the patient is recalled 1 to 2 weeks and repeat the treatment till the desired shade is achieved, and restore the assessed cavity with composite after 2 weeks. Here you can see the figure. First figure shows the removal of coronal gutta percha by using rotary instruments, and after that place the protective barrier over the gutta percha. And last one is the bleaching. Placement of the bleaching mixture that is placed over the protective barrier into the pulp chamber, and this sealing of cavity using any temporary restorations. Here also there is some complications present. Now we are moving to the next chapter, that is minimally invasive dentistry, and short essays asked can be classify remineralizing agent and explain in detail about CPP, ACP, and the short notes include air abrasion, lasers and micromechanical caries removal. And first we are moving to the classification of remineralizing agent. It can be fluorides, calcium phosphate based, calcium sucrose phosphate, sugar substitute, nanohydroxyapatite and bioactive glasses. Here you can see the examples. So these examples are very important, you can note it. Next one is CPP ACP, that is casein phosphopeptide in conjugation with amorphous calcium phosphate. It's a newer agent that will promote remineralization in incipient caries. And the major effects are, that is addictive effect on topical fluorides, there is increased microtensile bond strength to GIC, and it will also promote the release of fluoride ion from GIC. So these are the mechanism of action, you can note this flow chart. Next one is the application. So it is commonly applied as a topical, that is patients suffering from xerostomia, caries, lesions, erosions like that, to remove the white spot after orthodontic treatment, following bleaching, after scaling, after interproximal stripping, all this we can use. Next one is air abrasion. So this air abrasion, it works by spraying a powerful steam of a focused narrow beam of aluminum oxide that is of 20 to 50 micron in size and pressure 40 to 140, that is sprayed over that, and when these particles they are directed into the tooth surface, it will abrade and prepare the conservative cavity. So it will cut the enamel, dentine and also cementum. So the prepared cavity, it will be of minimum and it will be a saucer shaped, and it is well suited for composite restoration. The advantages and disadvantages, you can refer one or two advantages and disadvantages. Like advantages, no need of any local anesthesia, it is well tolerated to the patient. But disadvantages, it does not remove the soft caries and also expensive. These are the indication and contraindications of air abrasion. Indication can be used in minimal class 1 or class 2 preparation for composites, whitening pit and fissures for pit and fissure sealant. And contraindication, extensive cavity preparation, it cannot be used and not used in case of crown or veneer preparation. Next one is laser, that is for cavity preparation, hard tissue lasers, infrared areas of the electromagnetic spectrums are commonly used, and these are the two commonly developed lasers. And the advantages are there is no vibration and prepare conservative cavity preparation, and there is no need of anesthesia as in case of air abrasion. And the disadvantages similar to that of the air abrasion, that is expensive. It cannot be used in case of large cavity preparation, and it's also time consuming. Next one is chemomechanical caries removal. So it consists of any chemical softening of caries dentine that is followed by its removal by gentle excavation. So this is the more, it mainly consists of 3 amino acid, sodium chloride, sodium hydroxide, and so here you can see the chemomechanical caries removal. And so it is supplied in 2 syringes, that is the contents of the 2 syringes that is mixed together to produce a pink gel, and it is applied over the dentine and is placed for 30 seconds. So it will soften the infected dentine. After that, initially the cavity it is opened with a rotary burr to assess the caries dentine, and after that a special hand instrument is used to excavate the caries. So initially rotary instruments are used, after that a special hand instrument is used to excavate the caries, and the gel may be replenished from time to time till the caries dentine is removed, and the preparation has a slight frosted and irregular appearance, and it lacks smear layer. Next one is mechanism of action, and last one is advantages and also disadvantages. Next we are moving to chapter that is cervical lesions. Consist of short essays like abrasion, classify non-caries lesion, discuss in detail about management. Short essays includes abfraction and erosion. So classification of non-caries lesions, that is consist of attrition, erosion, abrasion and also abfraction. In case of dental attrition, it is the loss of tooth structure or tissue that is caused by tooth-on-tooth contact, and erosion, it is the loss of tooth substance by non-bacterial chemical process. Next one is abrasion. So it is the pathological wearing of the teeth due to abnormal process, habits or abrasive substance. And last one is abfraction. So it is the pathological loss of tooth substance due to any biomechanical loading forces that result in flexure and ultimate fatigue of enamel and dentine at a location away from loading. So these are the definition. Now we are moving to abrasion, and definition we have read early. So the etiology it consists of due to tooth brushing and also abnormal habits under toothbrushing, vigorous brushing, use of hard toothbrush, abrasive dentifrice, and abnormal habits like biting fingernails, opening bobby pins. Next one is abfraction. Its definition we have already discussed. And etiology includes excessive occlusal stress and parafunctional habits like bruxism and also clenching. Next one is erosion. Its etiology consists of both extrinsic and also intrinsic. In case of extrinsic, due to any dietary acids or environmental erosion. Dietary acids like citrus fruits, fruit juices, pickled food, etc. And environmental erosions like wine tasting, metal plating. And the intrinsic etiology due to gastric disorders and also eating disorders. Gastric disorders like ulcers, hernia, and eating disorders, and chronic vomiting and pregnancy, morning sickness. These are the clinical features of non-caries lesion. It's based on the location, shape, margin, enamel surface, and also teeth affected. So, it's based on that the clinical features are different from erosion, abrasion and also abfraction. Next one is the treatment options. The treatment mainly includes, first one is dentin desensitization, restoration, endodontic therapy and periodontal therapy. So first one is dentin desensitization. So it is the treatment option for those situations with minimum amount of dentin is exposed, that is less than 1 mm, and it can be managed by fluoride varnish, dentin bonding agent or use of any desensitizing toothpaste. Next one is restoration. So the restoration commonly consists of composite resin, copomer restoration and also GIC. And the last one is periodontal therapy, that is root coverage procedures using free gingival graft or connective tissue graft, and root coverage using non-grafting procedures like rotational or coronally advanced flap. Now we are moving to the dental ceramics, and the long essays include, first one is define and classify veneer, explain in detail about indirect veneers, and the short notes include CAD/CAM, ceramic veneers, direct veneer, and also last one is laminate veneer. So the first one, that is veneer definition. So very important definition. Is a layer of tooth colored material that is applied to the tooth to restore localized or generalized defect and intrinsic discoloration. And the classification, mainly direct resin is there, indirect resin and also porcelain indirect system. Here there is advantages of direct composite system. It's only one appointment and the dentist directly controls the color and form, and the cost of the patient is reduced and composite veneers are repairable. And indirect porcelain technique, that includes laboratory fabrication of the veneer, compensate for the shortcoming of direct composite resin technique, and the dentist may use the time saving and artistic skills of the ceramic. Multiple units can be placed with less chair side time. Next one is laminate veneer restoration, a conservative aesthetic restoration of anterior teeth to mask discoloration, restore malformed teeth and close diastemas and minor or any minor tooth alignment. These are the indications and contraindications in case of direct resin, indirect resin and also porcelain. And also there is aesthetic potential, expected longevity and ease of placement and repair difficulty. Next one is CAD/CAM. So these are the system that can design and produce restoration out of block or blanks of ceramics with aid of a computer. So it's a computer aided design or computer aided manufacturing. So these are the 5 essentials of CAD/CAM. that is scanner, computer, milling station, ceramic blanks and also furnace. It's a systematic representation of the CAD/CAM production. Now we are moving to next chapter, that is pathologies of pulp and periopex. And the long essays include define periradicular disease, classify them, describe the signs and symptoms of acute periapical abscess. And next one is describe periradicular disease and classify them, mention the signs and symptoms and treatment of acute periapical abscess. And the short notes include acute irreversible pulpitis, acute reversible pulpitis and also phoenix abscess. First we are moving to periradicular disease. So definition, it is a mass of chronically inflamed granulation tissue that is found at the apex of the non-vital tooth, and the classification both Grossman classification and also there is Ingalls classification. And in case of Grossman, there is symptomatic periradicular disease, asymptomatic periradicular disease, external root resorption, persistent apical periodontitis and disease of periradicular tissues of non-endodontic origin. And in case of Ingalls classification, that is painful pulpoperiapical pathosis and non-painful pulpoperiapical pathosis. Under painful, there is symptomatic acute apical periodontics and also advanced apical periodontics. And in case of non-painful, that is condensing osteitis, chronic apical periodontics and both incipient and advanced stages and also chronic apical periodontitis. So these are the classification, and this is the WHO classification of periradicular disease. Now we are moving to the acute periapical abscess. So in the figure you can see the acute periapical abscess, and it is also called as acute abscess, acute apical abscess or dentoalveolar abscess. So it's the inflammatory reaction of the pulp infection and necrosis that is characterized by rapid onset, pus formation, spontaneous pain, tenderness on percussion and eventual swelling of associated tissues. And this is the pathophysiology of the apical abscess formation. And the symptoms, common symptoms are, first there is tenderness of the tooth may occur, and later there will be a throbbing pain that with a diffuse swelling, and the tooth may become more painful as well as mobile. And also there is other systemic symptoms like fever and increased WBC count. And the spread of lesion towards a surface may cause erosion of cortical bone, and it may diffuse or spread widely that may leads to cellulitis. So also there is a location of swelling is determined by relation of abscess of involved teeth to adjacent muscle attachment. So these are the symptoms. Next one is the management. The common management is the drainage of the abscess that is initiated as soon as possible, and it also include non-surgical endodontic treatment, incision and drainage and also extraction of the tooth. So in case of localized infection, system antibiotic can be provided, but it is of no any additional benefits. And in case of any fever or lymphadenopathy, cellulitis, this antibiotic can be given in addition to drainage of the tooth. After that, to control the postoperative pain, this non-steroidal anti-inflammatory drugs can also be provided. So this is the management of the periapical abscess. So in the first figure you can see a deep caries that causing pulp necrosis that is followed by periapical abscess. So in the figure B you can see the initiation of the endodontic treatment. After that, by obturation of the root canal system, proper cleaning and shaping of the canal, after that it is obturated. Next one is phoenix abscess. So it is also called as acute exacerbation of asymptomatic apical periodontitis. So it is defined as an acute inflammatory reaction superimposed on an existing asymptomatic apical periodontics. And etiology is mainly due to any chronic periradicular lesions such as granuloma, or due to any influx of the necrotic products from the diseased pulp or bacteria that may cause lesion, and this also due to any acute inflammatory response. And the symptoms commonly includes, initially there is tenderness of the tooth and there is extrusion of the tooth from the socket, and on palpating the soft tissue the patient may feel pain or tenderness. And the diagnosis, it can be diagnosed from the history of the patient, and the pulp test it may shows negative response, and radiographically there will be large area of radiolucency in the apex that is created by inflammatory connective tissue which has replaced the alveolar bone at the root apex. And next one is the treatment. Here also drainage, establishment of the drainage, and once the symptoms subside, then the root canal treatment can be preferred. This is the differential diagnosis of reversible and irreversible pulpitis. So here you can see the features like pain type, stimulus, pain at night, postural pain, pain localization, referred pain, history, percussion, and the pulp test, if there is any color change, radiograph, and also treatment. So you can refer this table for any differential diagnosis of reversible and irreversible pulpitis. And this concludes that chapter. Next chapter is endodontic microbiology. In endodontic microbiology, commonly short note can be asked, that is culture in endodontics and culture media in endodontics. First one is the principles of culturing. So there are commonly two principles. First one is, in case of persistent lesions, to grow and isolate the microbial flora for antibiotic sensitivity and resistance profile, and to assess the bacteriological status of root canal system before obturation and determine the effectiveness of debridement procedure. Next one, the type of tissue cultures, and the commonly used cultures are cell culture, anaerobic culture, pure culture, primary, secondary, streak, like that. There are many types of tissue cultures, and the type of culture medium include liquid, solid, and also semi-solid. Next one is advantages. And in a case of advantages, this culture, it will helps to determine the bacteriological status of root canal. It also isolate the microbial flora and helps in the identification of broad range of microorganisms. And the disadvantages includes, it will enable to grow several microorganisms that may give a false negative results, and there is low sensitivity and also specificity. It's time consuming and also it's expensive. Now we are moving to next chapter, that is diagnostic procedures, and the short essays includes describe about different diagnostic aids used in endodontics and explain in detail about pulp vitality test, enumerate the pulp vitality test, describe cold test, enumerate different diagnostic procedures in endodontics, and briefly describe about laser Doppler flowmetry. And the short notes includes pulse oximetry, radiovisuography, thermal test, tooth sloth, use of radiographs in endodontics, use of mouth mirror vitality test, and electric pulp testing. First one is the diagnostic methods in endodontics. So here you can see various methods, and each of the methods are separately asked for any 3 marks or 5 marks. And the methods includes, first one is visual and tactile inspection, percussion, palpation, mobility, bite test, radiography, assessment of pulp vitality, and that includes neutral sensibility test and also pulp vascularity test. So under that there is there are subtopics, so you can refer that. First one is the visual and tactile inspection. So the 3 C's, that is color, contour and consistency, are commonly seen by using eyes, fingers, explorer and probe. There is both hard tissue examination and also soft tissue examination. And in case of hard tissue examination, the color like normally brown, life-like translucency. And the soft tissue examination, in the gingiva, the color is noticed like if there is any deviation from normal pink color to red, and contour there is any swelling, and consistency soft and fluctuant. The periodontium should examine in good light under dry condition. Next one is percussion to evaluate the status of the periodontium, and there are 2 types, that is vertical and also horizontal, and the tenderness on percussion should be abnormal. And the palpation, it is done with the use of fingertips by using light pressure to examine the tissue consistency and also pain. And next one is mobility and depressibility, that is moving the tooth vertically in its socket. And mobility, it means to evaluate the integrity of attachment apparatus around the tooth, and the movement, it may indicate the condition of the periodontium. Next one is bite test. It is commonly used in identifying the cracked tooth or fractured cusp when the pressure is applied on certain directions to one cusp or section of teeth. And commercially available devices for bite test, tooth sloth or fract finder. And tooth sloth, that is, it is a small pyramidal shaped plastic bite block. It has a small concavity at the apex of the pyramid to accommodate the tooth cusp, and a small indentation is placed over the cusp, and the patient is asked to bite down. Thus the occlusal force is directed to one cusp at a time, exerting desired pressure on the questionable cusp. Magnification, that is dental operating microscope, that is locating hidden canals obstructed by calcification, detection of cracks or any fractures. And next one is radiography, that is IOPR and CBCT. Assessment of the pulp vitality, that is neural sensibility test and also pulp vascularity test. Under that there is thermal test, hot and heat and cold test, and electric pulp test, anesthetic test, test cavity. And in case of vascularity test, that is pulse oximeter, laser Doppler flowmetry and others. Now we are moving to the first one, that is thermal test. This application of both heat or cold to the teeth to determine its sensitivity. And the heat test, the materials used are electric heat carrier, hot GP stick, and others like hot burnisher, hot compound and hot rubber polishing wheel. And this is the procedure of the heat test. So the mechanism of heat test. Next one is the cold test. The materials used can be dry ice, pencil of ice cold water, under rubber dam isolation and ethyl chloride. Here also mechanism of cold test is there. Next one is electric pulp test, that is uses the nerve stimulation, and the major objective is to stimulate a pulpal response by subjecting the tooth to an increasing degree of electric current, and positive response that indicate the pulp vitality, and if there is no response it will indicate there is pulp necrosis. Here also there is procedure. This one is the interpretation, that is normal response when there is negative response, non-vital tooth, that is failed to response even at the highest electric excitation value. Early response, there is diseased state of the pulp threshold at the low level than control tooth, and delayed response, that is diseased state of pulp threshold at higher excitation level than control tooth. Next one is anesthetic test, that is restricted to patients who are in pain at the time of test when usual tests have failed to identify the teeth, and the objective, that is the tooth is anesthetized at a time until the pain disappears and it localized to specific teeth. Here also technique is infiltration is given, and posterior most teeth is injected. And if the pain persists, move the next tooth, and to differentiate the maxilla and mandible, IANB is given. Next one is test cavity. So it is performed when other tests are all failed. So this drilling the tooth through enamel dentine junction of the unanesthetized tooth using a rotor. If there is sensitivity or pain is felt, the pulp is vital, then no endo treatment is required. And if there is no pain, the preparation continue till the pulp chamber, and if the pulp is completely necrotic, then the endo treatment is decided. Next one is pulp vascularity test, that is pulse oximeter. So it is a non-invasive method to measure the oxygen saturation level during administration of anesthesia or other medication with the help of finger, ear or foot probes. Usually there are usually the parts includes two LED, that is red light and also infrared light, photo detector, pulse oximeter monitor and pulse oximeter sensor, finger sensor and pulse oximeter sensor holder. And this is the figure showing the mechanism of pulse oximeter. Here are the principles. It consists of two LEDs, that is first one is red light and also infrared light, and a photo detector on the opposite side, and this LED transmit red and infrared through the vascular bed, and this oxygenated HB and deoxygenated, it will absorb the different amount of infrared and also red light. And after that, the pulsative changes in the blood volume, it causes periodic changes in absorption of the light by vascular bed before reaching the photo detector. These pulsative changes, it will analyzed by pulse oximeter and it will determine the saturation of arterial blood. Next one is laser Doppler flowmetry. So this is also a non-invasive method for assessing and accurately measuring the rate of blood flow in tissues. So it is a technique sensitive. It will require splint to hold the sensor in place. Here also you can see the principle. Next one is uses of radiograph in endodontics, mainly used in case of diagnosis, during various treatment steps and for evaluation of success or failure of the treatment. And in case of diagnosis, to identify the pathosis and also any lesions, root curvatures, bifurcations, unusual root morphology, etc. Characterizing the normal structures helps in differentiating the normal from abnormal. And use of mouth mirrors. These mouth mirrors are used to provide a clear and distinct vision of the operating area. So the functions, this is also commonly, as you all know. Radiovisuography, RVG, it has the ability to capture, view, enhance and also store the radiographic images. So it has an intraoral sensor that will capture the image by radiation source, and this sensor, it is a fluoroscopic sensor, a set of optic fibers and a miniature chart coupling device that translate the image, and an electronic signal is produced which is displayed. This sensor, it is attached to the computer which interprets the signal and transforms it into digital image, and this image, it is instantly displaced and visualized in the computer, and after that the image is stored and is recalled whenever required. This is RVG, and the advantages here, the X-ray film is not used and there is no distortion and the image is cleared. So the disadvantages are it is expensive. Now we are moving to the last section, that is pharmacology in endodontics. Some rarely asked questions. Short essay, that is discuss briefly about local anesthetic technique and principles of assess cavity preparation in endodontics and classification of antimicrobial drugs. First one is antimicrobial drugs. It consists of antibacterial, antifungal, antiviral, antiprotozoal, and anti-helminthic. So first one is antibacterial. It includes penicillin, aminoglycosides, erythromycin, and antifungal, amphotericin, ketoconazole, antiviral, acyclovir, like that, antiprotozoal, and also antihelminthic. Local anesthetic technique, and the main local anesthetic techniques includes, first one is local infiltration, that is the small nerve endings in the area of dental treatment, they are flooded with local anesthetic solution. Next one is field block, that is local anesthetic, it is deposited near the large terminal nerves branches so that the anesthetized area will be circumscribed, preventing the passage of impulses from the tooth to the central nervous system. And last one is nerve block. At the local anesthetic, it is deposited close to the main nerve trunk, that is usually at a distance from the site of operative intervention. First, it is in the area of dental treatment, local infiltration, and field, it is near the large terminal nerve, and last one is nerve block, it is deposited close to the main nerve trunk. So these are the important points. Next one is maxillary injection technique, and the commonly used maxillary injection techniques are supraperiosteal, intraligamentary injection, intraseptal injection, intraosseous, posterior superior alveolar nerve block PSA, middle superior alveolar MSA, and anterior superior alveolar nerve block, that is ASA, and the maxillary nerve block greater palatine, nasopalatine, and anterior middle superior alveolar nerve block, and also palatal approach. Now we are moving to the mandibular anesthetic technique. So the most important one is the inferior alveolar nerve block, and along with that there is buccal nerve block, mandibular nerve block, Gaugate's technique, Vesrani Akinosi closed mouth mandibular nerve block, mental nerve block, and last one is incisive nerve block. And in case of mandibular anesthetic technique, this inferior alveolar nerve block is the most important one, and also Gaugates are also commonly used. And the inferior alveolar nerve block, in this block it may anesthetize the area or the lower mandible and half portion of the teeth from the incisor to the posterior most teeth. And so this inferior alveolar nerve block is very important. It's a commonly asked question. So here ends the today's section. Hope you all understood, and we will come back with another section. If there is any doubt, you can post it there. And thank you all for hearing my words. Thank you.